Hi, I'm Dr. Allam Perel, and this is Conversations in Medicine. This program brings cutting-edge topics in medicine to the Staten Island and tri-state community. So thank you all for tuning in. We're going to be talking about hand surgery and hands themselves. We think about our hands doing so many wonderful things, and we would not be human without our hands. And there's sometimes a lot of problems with hands. Injuries to the hands, sports injuries, things that we do, accidents that occur, arthritis, all kinds of things. And there's a whole field of medicine and surgery called hand surgery. And we have one of the best out here. And I'm going to really say it's my true privilege and honor to have Dr. Nadubeethi Jayaram here with us. And he's a wonderful hand surgeon at Richmond University Medical Center where I work. And we see a lot of patients in the community together. And we're going to talk about hands and different things that we could offer patients, and trying to always go into the fact that our wonderful audience, that people shouldn't live with problems. You know, as a neurologist, I have people with numbness in their hands, pain in their hands for years and years, and they didn't really know where to go. And sometimes we're able, and that's what the beauty of medicine is, sometimes we're able to come up with something that really changes the people's lives. So let's get started and talk about what kind of a physician is a hand surgeon, what kind of training do you have, and maybe at the end I'll even ask you why you became a hand surgeon.
First of all, you've got to be a surgeon. You can be either a general surgeon, plastic surgeon, or orthopedic surgeon, and then ideally, you should do 1 year of fellowship training in a major university center where there's a good hand surgery program. At the end of that year, you would have seen all kinds of problems related to the hand, both in children and adults, and be able to address the problems in your practice.
So let's go into the hand. So how far does the hand go up? We think about the hand. Is it the fingers? Is it the wrist? Is it the elbow? Tell us, in a sense, if you're having discomfort or pain and you're telling your internist or primary care physician, they have to make a decision whether to send someone to a hand surgeon. And tell me how far up you guys go.
Orthopedic surgeons tend to go higher than the other surgeons. Orthopedic surgeons go from fingertips to above the wrist, including the bones of the wrist. But the plastic surgeons and general surgeons will tend to stop below the wrist and handle only the fingers and the major portion of the hand. They don't usually go into the wrist because that will be orthopedic territory and may need different kind of approaches for treatment of the wrist injuries.
Because the orthopedist does all joints in the body, and all bones in the body, so they're not uncomfortable going a little bit higher up and seeing if there's problems.
That is true. We are more familiar with the anatomy of the entire arm, so we feel comfortable handling those problems.
Okay. So we're going to jump in now to abnormalities of the hand. I see you have your atlas, and we're going to talk about some pictures. But just to make this regular for all of us, so there's sports. People get angry. We always hear the story about someone punching a wall. An athlete, usually a man, just punching a wall in true frustration. Now, when someone punches a wall, and sometimes people get upset even at home, and somebody will bang their hand, what kind of injuries do we oftentimes see?
First of all, it's usually a male who is relatively young, a lot of hormones flowing through the body, and their fuse is very short, and they take it out on themselves by hitting a wall and break something in the process. The injury that you most commonly see, 40% of the time in these situations, is a boxer's fracture. Boxer's fracture would be a fracture of the fifth finger, where the hand connects to the finger. This part of the hand connects to the finger, and the fracture is in this area, just below the knuckle joint. And usually it gets displaced. Displaced means there will be an angle. And depending upon the angle, they may need splinting, or if the angle is more, we have to try and straighten it up by giving local anesthesia and put a splint on. If that doesn't hold, then may need surgery. Surgery is not very common for this condition. So we can treat most of the time by splinting and reduction by manipulating and putting a splint on. We always check with X-rays and keep checking with X-rays every 2 weeks. Make sure it is not slipping out of place so that the patient will have a successful outcome.
How interesting. So as we're sort of alluding to, let's go over this. Younger people, middle-aged people, older patients, you can almost tell, and again, as a neurologist, I could see there are patients who come in with very specific problems. Usually when a 20-year-old woman comes into my office, they come in with headaches. Again, there are other things, of course. When a 75-year-old person comes in and they're not walking well, we're always worried about things like Parkinson's or with memory problems like dementia. So based on the age, I sort of have a characteristic of what patients might describe. So in your practice, when you have youngsters come in, and maybe you could even define it, what problems do they usually have?
A lot of the injuries are sports-related injuries, and they, especially in basketball, they jam their fingers against the ball, and the finger bends a lot more than it is allowed to bend. In the process, by overdoing the bend, the ligaments will tear, and that can result in some consequences like deformity and stiffness if it is not properly treated. This should not be treated trivially. Even a sprain should be treated with utmost care, proper splinting, and do things in a proper sequence to have a successful outcome.
So tell me about basketball, because I mean, a lot of our viewers out there play basketball. My son loves to play basketball. I'm sure your family. They always get their fingers jammed. So what happens if you're playing ball and your finger gets jammed and it hurts? I mean, I've had this happen to me in my younger days. What would you do at the time of the injury?
My sincere request is go see a doctor. Don't try to treat it by yourself thinking that everything is going to be fine. Once the pain goes away, everything may not be fine. You may be left with a deformity, which can be permanent actually. So have it examined, have an X-ray done, make sure there's no fracture, make sure there's no major ligament damage, and if there's a ligament damage, treat it with splinting, and usually splinting for 2 to 4 weeks is necessary, and then we remove the splint after it is healed enough, and then may need physical therapy. Otherwise, you can develop deformities.
Tell me about prevention. I mean, in medicine, we're always trying to get people to prevent having problems. Is there anything that youngsters could do when they're playing, whether it's basketball, soccer? There's all these other sports that you could jam your fingers and have problems with your fingers also. Is there anything that you would recommend that young people do to prevent it?
Number one, don't participate in multiple sports. And when you're tired, don't play sports, because that's when you are prone for injuries, because you're letting down your guard. If you're tired, you definitely will get injured more frequently than when you are alert and in good shape. And multiple sports, you suddenly have to change tack there and move in a different way, and in the process, you can get hurt.
Interesting. So let's go to the million-dollar issue. When we talk about hands and people think of surgeons, the word carpal tunnel syndrome comes up. And that's such a common process that people have. As a neurologist, I see people with numbness in their fingers. People are worried that they might have had a stroke or something terrible. And they're sometimes very much relieved when I say, oh, it's a carpal tunnel syndrome after whatever electrical tests we come in, or even just clinically. So carpal tunnel syndrome seems to be a large part of what hand surgeons are involved in, of course, with fractures and sports injuries too. But I think for our viewers, that's the kind of thing where maybe you could just even describe from the beginning. Like as a neurologist, people will describe to me they've got numbness in 3 fingers that wake them up at night. You know, when they wake up in the morning, they've got tingling. From an orthopedic hand surgical approach, tell us a little bit about carpal tunnel syndrome, and by the time people get to you, they're considering surgery. How do you decide if someone's going to have surgery? And then we go to, right after that, we've got some models, and we'll talk about how do you do the surgery, what it is.
One of the most important things for you to realize is you need a proper examination, because the symptoms that you feel, symptoms is the changes in your hands, like numbness, tingling, burning sensation, can be arising from several areas. It could be coming from the neck, from arthritis in the neck, pinched nerve in the neck, slip disc in the neck, or it could be pure carpal tunnel syndrome due to a tight ligament in the wrist, or it could be a combination of both neck and the hand. We call it double crush syndrome. And then the third thing is in diabetes and neuropathy, especially insulin-dependent patients, in diabetes can develop neuropathy, and we have to sort all of this out before we drop our knife and do any surgery. Here where a multi-specialty group comes in, like neurologists, like yourself. We do an EMG and nerve conduction studies. EMG stands for electromechanical conduction. Number 2 is nerve conduction study, and this will show us where the pressure is on the nerve. Is in the neck, is it in the wrist, or is it in the elbow, or is it pure neuropathy due to diabetes, or a combination of all this. We do see a combination of all this too.
So, of course, diabetics, because of nerve issues in their hands and feet, are more prone to get carpal tunnel. So maybe just even, I don't know if we need to look at your model, maybe you could tell them, because people want to know about carpal tunnel. As a simple neurologist, there's a hole, there's a tunnel, like the battery tunnel or the Holland tunnel, whatever the name is right now, and there's a nerve that goes through it, and it's too tight. But there's a lot more to it. There's ligaments around there that do this. And then the way I explain it is that we cut the top of that and we give the nerve space. So again, that's a very simple, non-surgical approach to how we treat people with carpal tunnel. Let me ask you, when should someone see a doctor for numbness in their hands or pain in their wrist or things like, if you think it's a carpal tunnel, is it wise to go to the doctor and see whether you might need surgery?
Well, that's a very good question, Dr. Perel. Sometimes a lot of people feel transient numbness and tingling in the fingers, sleeping the wrong way, pressure on the wrist the wrong way, pressure on the neck the wrong way. But if it tends to be persistent is lasting more than a few weeks, almost every day, that wakes you up from sleep, and then you're developing weakness in the grip, you notice numbness while driving, and it gets to be annoying, and your sleep is lost. At the end of about a month or 2, you should certainly seek expert opinion regarding this.
Because everybody could wake up with some numbness in their fingers.
Yes.
Sometimes people sleep, they're in a weird, awkward position. And why does carpal tunnel syndrome occur at night when you're sleeping? Because we all sleep like this. And we're all putting pressure on that area.
You've got a very good point there, Dr. Perel. Human tendency is to curl up when you're sleeping. So the wrists get bent. In a bent position, there's more pressure on the nerve inside the carpal tunnel. So, and also during the nighttime, what happens is you tend to accumulate fluid in the tissues. Fluid is the water content in the tissues will increase, and that'll occupy more space in the carpal tunnel and also cause more pressure on the nerve and cause numbness and tingling. And once you start moving, when you wake up, you shake your hands, and the numbness tends to ease. That's because the fluid is being mobilized. During daytime, you're also moving frequently. There's not much fluid that accumulates in the wrist because of the activities that you are doing. So that's the reason. So
when do you think patients require surgery? So, I mean, as we said, you're allowed to have some numbness occasionally. It gets better. It lasts for a few weeks. Many patients are hesitant to have surgery. So what's your criteria to when I can give you, what I see, or electrical diagnosis to see how badly the nerve is working? And those are things that you will work in unison to figure out whether a surgical approach is there. Maybe if you could first say, what non-surgical approaches to carpal tunnel syndrome? Any thoughts or anything that you recommend to your patients?
First of all, I would take a thorough history for every carpal tunnel syndrome patient. I ask the history of diabetes, any thyroid disorder, rheumatoid arthritis, and then apart from the medical conditions, is there any pain in the neck, which may be causing some pinched nerve in the neck, or does the patient have diabetes? Does the patient have peripheral neuropathy, any past injury and alteration of the anatomy in the wrist? So all this history. After this history, then I examine the patient and see what the muscles look like. If the muscles are shrinking, then it's of more urgency there to do something about this. But we don't drop a knife right away. We do a nerve test. That's the
EMG, as you mentioned,
EMG, a nerve conduction study. That's where the neurologist comes into the picture. So he does the test and gives me his expert interpretation, which I depend on before I drop my knife. And if it shows significant pressure on the nerve, then we offer the surgery to the patient. Yes.
So let's go over. I think we have some of your wonderful models, and this is one of the largest atlases that I've ever seen in my life. And it's the largest atlas that we've ever had on Conversations with Medicine. And David, if we could put up one of the slides, slide number 1, and maybe we can go over some of the things, how many bones are in the hand, and people talk about the multitude of bones and what could break. So maybe give us a little bit of an idea of that what we're watching.
This is a picture of all the bones in the hand. The anatomy of the hand is very complex. Everything is jam-packed there in a small area. Each finger has so many things jam-packed into each finger. There is skin, there is fat, there is bones, there is nerves, there is blood vessels, ligaments, joints. All these things are jam-packed there. Let's go to the next picture.
Here it comes, right?
Here, I'm showing you the neck for a very interesting reason. Especially in carpal tunnel syndrome, you need to know if there is any neck problems there, if there is any pinched nerve in the neck, and if all of the numbness is due to pinched nerve in the neck, then doing surgery on the hand without looking into the neck is the wrong thing to do. Patient will not recover. So that's where the neurologist comes into the picture. This picture shows the nerves exiting from the neck and going to the arm. You can see the white structures there, like a web. And those are the nerves going into the arm. And then the picture on the right side is a cross-section of the carpal tunnel. I drew the picture myself. The outer ring is the skin. Coming to the inner ring, in the bottom, there are 4 bones arranged in a row, and the bridge from one bone on the left to the second bone on the right, that blue bridge is the ligament. In combination, the bones and the ligament form a tunnel. That space is called the carpal tunnel. Inside the carpal tunnel, there are 9 tendons jam-packed there. Those are all in black. And the red circle there is the nerve in front of all the tendons. So if there is any swelling inside the carpal tunnel due to fluid accumulation or alteration in the anatomy of the bones, or if the ligament becomes thick, like in carpenters, seamstresses, those who use the computers a lot, it will encroach on this finite space inside the carpal tunnel and squeeze the nerve. The tendons don't have any nerves there, so tendons can handle the pressure, but the nerve cannot. When the pressure is exerted on the nerve, the passage of electrical signals is slowed down dramatically and significantly. Depending upon the severity of the pressure, we can measure the slowing of the conduction of the electrical signals, and the neurologist does that, and I depend on him for giving me the interpretation.
So let's go over, and we'll go back to us now instead of just looking at pictures. Tell me, the surgical procedure. And for many generations, it was an open, they make a cut and do this. And you were telling me a few moments ago before we went on the show about some of the very new procedures that might be better for certain patients. And maybe give us an idea of who would benefit from one procedure or the other. Everyone's looking for, and maybe even talk about lasers and endoscopic, or basically they look through a light, and you're the one who does it. So maybe try to explain to our audience about really the procedures, and then we'll talk a little later about the recovery, because that's the key. The reason we do smaller incisions and less invasive procedures, that people get better faster. So tell us, if someone comes in with a carpal tunnel syndrome, not a problem in their neck, not a problem in their arm, nothing in the other nerves, and you decide that it's just affecting their life because the hand is shrunken, some of the muscles are too thin, there's nerve damage there, there's numbness, someone can't pick up a pen, someone can't sew, someone can't write, all the things that we're worried about with people and we don't want to lose function. Tell me a little bit about what procedures we have available.
The oldest operation is the open technique. We would make a 2-inch incision approximately in the palm of the hand. That's almost vertical along one of the creases in the palm. And then under the skin will be a ligament, will be some fat. We separate the fat, expose the ligament, and then look for the artery at the far end and find the ligament and make a cut in the ligament, a small cut, and then pass a protective device inside the carpal tunnel and cut the rest of the ligament from the far end to up to the wrist crease. And then look at the nerve, make sure all the pressure is released. This is very important. If you don't release the entire ligament, then patients will still have residual numbness. So you have to guarantee a complete release so that they recover completely. This was the gold standard before. Now, the downside to this is it's still a good operation, but the downside to this is they take longer to recover.
How long does it take to recover?
It takes easily 4 weeks for a person to go back to work. For example, a nurse working in the hospital, she's out of commission for approximately 4 weeks. They have to lift patients, push, pull, and all these things. And there's a scar which becomes sensitive sometimes, so they will take about 4 weeks, sometimes even longer than that. Now, this is 2023, and we are seeing more advancements. And the next in line of the advancement after the open release was the endoscopic release. That procedure is also good, but there's certain drawbacks to that. You don't actually see the nerve, you see only the ligament in that.
So what is it endoscopic? You put a scope in?
You put a scope, you make a small incision at the wrist level, and then pass the instrument with the knife and deploy the knife and pull it back here. Here, you see only the ligament. You don't see the nerve. I would like to see the nerve also. I would like to see the blood vessels, make sure I don't damage anything during the process. So I've done that, but I feel uncomfortable doing that. Now I don't do that anymore. Now the next stage is, the latest, is ultrasound-guided carpal tunnel release. So what it means is we make the same incision. We do it purely local anesthesia, no tourniquet. And then we, under the ultrasound guidance, which we see on the TV screen, we pass the needle with the local anesthesia right up to the end of the tunnel, inject it gradually and pull it back. Following that, we enlarge the space there, all through the same incision, and then pass the device, which got a knife at the end and balloons on the side, which will push the nerve away, blood vessels away, so that when we deploy the knife and draw it back, cutting the ligament, there's no chance of cutting the nerve or the blood vessels. And you can see the actual cut inside. And
how long does it take to recover from that procedure?
Following this kind of procedures, a lot of patients have gone back to work after 1 week. So they may take 2 weeks. Some patients may take 2 weeks. One patient went golfing 5 days after surgery. But I'm not going to push that. I caution my patients not to really push it. Take it easy for at least a week, and you'll be fine. And we don't use any stitches with this ultrasound-guided procedure. Just a tape. We tape the edges together, and it works out nice.
Well, that's marvelous.
Yeah.
So when patients have carpal tunnel syndrome, I think one of the things that I see in my practice, and I'm sure you see too, are people who waited too long, who wait very long, and their hand is almost not functional. It's really much weaker than it should be. There's atrophy, there's numbness. And the first question everyone asks is, when I have the surgery, will I get back to the way I was? And what do you tell them?
Dr. Perel, that's an excellent question. It's not an easy question to answer, but I take everything into consideration. If the patients don't have very severe peripheral neuropathy related to diabetes, and they still have a component of carpal tunnel syndrome, when the EMG and nerve tests are done, I still recommend surgery in these patients, because we need to preserve protective sensation. The protective sensation comes into the picture in this group of patients, older patients who had carpal tunnel syndrome for a long period of time. They can be helped to preserve what they have currently, whatever sensation. Left alone, even that will disappear. The downside to this is if all the sensation disappears, they can cut themselves with sharp objects without knowing it. And then they can burn their fingers by touching hot objects without knowing that it's hot. So we want to protect the protective sensation. And it seems to this good surgical release, a complete release, seems to help preserve the protective sensation. Sometimes the bonus is they may recover a little function.
And I always tell our patients is it could always get worse. So never think that nerve can never be worse than it is.
Yes, sir.
So even if it's slightly weak or moderately weak, it can become severely weak. So we want to preserve, as you said so well. So I'll ask you almost on the medical side, with the ultrasound guided, you said some of the older patients, many of our seniors and even middle-aged patients are on blood thinners. Are they able to do this procedure with blood thinners, or do you have to stop all the blood thinners before you do it?
We recommend stopping blood thinners with open technique and also with the ultrasound guided procedures. There seems to be less bleeding with the ultrasound guided procedure. So the recommendation is to try and stop the blood thinners.
Okay, and that's important because so many patients are concerned about stopping some of their medicines, but we really do have to prevent a lot of complications. So in the last couple of minutes that we're here, is there anything that you want to talk about, anything new in hand surgery that everybody, all of our wonderful viewers who have listened to you and your wonderful expert opinion, say, wow, I never knew we could do that?
We can't go wrong with doing a basic good examination. That's the most important thing. You need to see a doctor who spends the time, because hand is so complex. Do a thorough evaluation is very important. You can't treat anything cursorily and miss a few things to make the proper diagnosis. That's the most important thing I can recommend.
Absolutely.
And number two, do the appropriate tests. Don't skimp on the appropriate tests. If necessary, go ahead and do the test. Is it EMG, nerve conduction studies, X-ray, MRI? All these have to be decided. And the current techniques are we are using more of ultrasound devices now to find some of the things there. It's still undergoing evolution, but the ultrasound-guided carpal tunnel release is definitely a big plus.
It sounds like it is. So I'm just going to ask you a quick question, and I sort of know the answer, but I'll ask the listener because I think it's important for our viewers. Procedures like this, do people have to go into Manhattan to some of the most world-famous hospitals to get these procedures done? When you're talking about your qualifications, of course, the specialty in hand training, we've only got like 10 or 15 seconds left. Tell us, do you feel comfortable for a family member to have this done on Staten Island, in the outer boroughs?
Yes, that's a good question. There are a lot of good fellowship-trained hand surgeons on Staten Island. I'm not going to claim that I'm the only one. But please go see a good hand surgeon.
Someone who is a hand surgeon.
Hand surgeon, preferably, especially when you have complicated problems. You need someone who has the knowledge and the patience to examine you and arrive at a proper diagnosis.
I'm going to say thank you because we're out of time. You were a wonderful guest, and I hope to have you back, and we'll finish up all our conversations. Thank you again.
Thank you.